So we're going to look at the tricuspid valve today. So you have to know everything about the tricuspid valve. As you're aware, the tricuspid valve is situated between the right atrium and the right ventricle. There are three leaflets. You have an anterior, posterior, and a septal leaflet. Okay, so you have to know when you get a view, you have to know which of the leaflets you're looking at. Okay. So it is the septal anterior and posterior. When you do your Doppler across over the right side and in the tricuspid inflow, you'll find that the velocities, as you are aware, the velocities and pressures on the right side are less than those on the left. So what you will see is that the peak velocities across the tricuspid valve is usually much less than 1 meter per second, and you get respiratory variation. To distinguish stuff going on in the right heart from stuff going on in the left heart, one of the distinguishing features is respiratory variation. On the right side of the heart, you get more respiratory variation in stuff. So when you look at the tricuspid regurgitation, you'll see there is respiratory variation. When you look at tricuspid inflow, you'll see respiratory variation. And if you recall, with inspiration, you tend to get increased blood flow in the right side of the heart. And because of that, velocities and pressures tend to be a little bit higher with inspiration as opposed to expiration. Okay, so the tricuspid complex consists of the coordinate tendineae, which anchors the valves to the papillary muscles. This is supposed to be three. Okay, so you usually have three papillary muscles on the right side as opposed to the left side where you'll have two papillary muscles, and you have a fibrous annulus where the tricuspid valve is anchored. So be very familiar with the tricuspid valve. What about diseases affecting the tricuspid valve? Pathology affecting the tricuspid valve include tricuspid stenosis. That is, the valve is not opening properly and the opening is stenotic, it's narrowed. Rheumatic heart disease can affect the right side. However, it's usually a left-sided disease, mitral valve, aortic valve, but you can get rheumatic mitral valvular disease. Carcinoid is a big one. They love to bring that in tests. Carcinoid basically is usually a gastrointestinal tumor which secretes these carcinoid material, and it produces this wax-like deposit on in the right side of the heart. So just imagine a waxy material building up on the tricuspid or the pulmonic valve. It's going to make the valves stenotic and incompetent at the same time. So that's carcinoid. It's usually a tumor in the gastrointestinal tract. You can have tumors itself affecting the tricuspid valve. So just like on the left side, you can get myxomas, or you can get papillary fibromatosis, or you can get papilloma. Okay, so you can get papilloma of the valve, vegetation, so infected material, and you can get vegetation on the valve leaflets itself. One of the neglected pathology of the tricuspid valve is damage from pacemaker lead. This is real. I mean, you know, I once saw a patient, the tricuspid was wide open because the lead was very taut and it presses down on the tricuspid valve and most likely damage the valve. Okay. And usually when you get something like that, you think, okay, if I just change the pacemaker lead and stuff. No, the treatment for this is tricuspid valve replacement. So a simple thing like that, you have to replace the tricuspid valve. So, you can create a lot of problem if the pacemaker leads are not properly implanted. Aneurysm of the sinus of Valsalva can affect the tricuspid valve because it's because of the close proximity, and prosthetic obstruction if you have a prosthetic tricuspid valve. So what are some of the signs and symptoms, the clinical features that these patients are going to have? We're looking at tricuspid stenosis now. So the tricuspid valve is not opening. The blood cannot get from the right atrium to the right ventricle, so you have a buildup of blood in the right atrium. So the patient will tell you they have this fluttering discomfort in the neck because of the blood building up in the right atrium and going back into the jugular system. Fatigue because of probably decreased cardiac output. Patient will tell you that they're fatigued, cold skin because of probably decreased cardiac output. Right upper quadrant abdominal pain, and that is because, again, the right atrium is engorged because blood cannot get out of the right atrium. Blood backs up into the inferior vena cava, into the hepatic vein, so the liver becomes enlarged and the capsule becomes tense. So patient develop pain in the liver, which is in the right upper quadrant area. So if you just palpate that area, they'll have tenderness, and you can feel the liver being enlarged. Jugular pulsations, because of, again, the blood backs up into the right atrium, backs up into the jugular vein, and you can see huge jugular veins, and you can see it pulsating. So if you're going to listen with a stethoscope, you get what we call a pre-systolic murmur, or best at the lower left sternal body in about the fourth intercostal space, and it increases with inspiration. Again, almost all murmurs on the right side is going to increase with inspiration because of the increased blood flow into the right side of the heart with inspiration. So you get this pre-systolic murmur, or that the lower left sternal border, which increase with inspiration. So that is, and tricuspid stenosis is not very common, but again, if you have a patient who has carcinoid syndrome, so carcinoid, again, it's usually a tumor in the GI tract which secretes these waxy material that builds up on the valve. So the valve becomes like it's encased in wax. All right. All right. So this is let's see what case this is. So it's a case of a tricuspid valve in a patient with carcinoid syndrome. So this explains it clearly. Of course, your echoes are not gonna come labeled like this. So if you look here, this valve is fixed in place. Okay, this is supposed to be a systolic frame because you see the mitral valve is closed. Okay, it's supposed to be a systolic frame. And again, if you look there, the markers at the onset of the QRS. So it's supposed to be no, it's a marker. That's supposed to be a diastolic frame. Anyway, this is a systolic frame. The mitral valve is closed. But when you look over here, you can see that the tricuspid valve is open. That's because it's fixing that position. Because again, carcinoid syndrome usually is a tumor in the GI, the gastrointestinal tract that secretes this material that it's like a waxy material which deposit mainly on the right sided valves, and you can see the valve is fixed in position. So the valve it's going to be stenotic and regurgitant at the same time. So these patients are going to have both stenosis and regurgitation. And if you look at your Doppler right there, okay? So you can see that there is a diastolic uh, signal, and then there's also a systolic signal. This diastolic signal, okay, is your this diastolic signal is your tricuspid inflow. And if you just do planimetry, you will get an idea of how stenotic the tricuspid valve is. And then this systolic signal is your tricuspid regurgitation. Okay, you can see it looks like it's triangular, so it's probably pretty severe. That is because the valve is both stenotic and regurgitant. Okay, all right, so all right, so this is so this is again, this is a tricuspid valvular pathology, and this shows it pretty good. This is the TR, and this is the tricuspid stenosis. So remember, in diastole, tricuspid valve is supposed to open, and it's supposed to be non-restrictive. But if you do planimetry there, you can see that when you do the TVI, the gradient is about 9 millimeters mercury. So there is some significant tricuspid stenosis, and then you have tricuspid regurgitation. Okay, you can see the atrium is huge, huge right atrium. Okay, so the valve is both stenotic and regurgitant. All right, so these are the numbers you need to know for tricuspid stenosis. Um, for significant or hemodynamically significant tricuspid stenosis, the mean gradient is usually greater than or equal to 5 millimeters mercury. And the time velocity integral, this is again across the tricuspid inflow. So when you look at this and you do planimetry of the tricuspid inflow, the mean gradient greater than or equal to 5, the TVI greater than 60, or if you do the pressure half time greater than 190. And if you calculate the valve area by the continuity equation, less than or equal to 1 centimeter squared. These are all findings of severe or hemodynamically significant tricuspid stenosis. Okay, and again, if you have hemodynamically significant tricuspid stenosis, then the right atrium is going to be enlarged, the inferior vena cava is going to be dilated. So just think about it. I mean, it's supposed to heads up, straightforward. No, tricuspid regurgitation. This is very, very common. So you're supposed to know everything about tricuspid regurgitation because this is a very common pathology. Almost all the patients that you come across have some degree of tricuspid regurgitation. So approximately 70% of normal individuals can present with a small degree of tricuspid regurgitation, and they may ask you this in your exam. You may get a question like this: It's very, very common. Upwards of 70% of patients, normal individuals, will have some degree of tricuspid regurgitation. And because they do, this lends itself for you to calculate the right ventricular systolic pressure and the pulmonary artery systolic pressure. So you can calculate those pressures because TR is so common. So what are some of the causes of tricuspid regurgitation? So we have primary causes. That is, when we say primary causes, these are conditions that affect the valve itself. The valve is involved in the disease. So again, rheumatic heart disease, you can have direct involvement of the tricuspid valve. Myxomatous change, so, similar to mitral valve prolapse, the tricuspid valve can become redundant and prolapse. Epstein anomaly, they love this because it's one of those congenital things that, sometimes you can see it in adults, um, where the septal leaflet of the tricuspid valve is apically displaced. And when you look, these patients have huge, giant right atrium and very tiny right ventricle. So Epstein anomaly. Endocarditis again can cause tricuspid regurgitation because if you have anything on the tricuspid valve which prevent proper coaptation of the valve leaflets, it can become regurgitant. Leaflet tear or prolapse of the chordal or papillary muscle structure. It's fairly common, or it's not uncommon then for patients, driving unrestrained, meeting an accident, and the chest hits the steering wheel, and you can rupture the tricuspid valvular apparatus. Okay, so I've had a couple of patients, not one, more than one patients who have had these type of injury. You have to replace the tricuspid valve. So that can occur, can have papillary muscle rupture on the right side, giving rise to tricuspid regurgitation. As mentioned before, the carcinoid syndrome or carcinoid disease, pacemaker or defibrillator lead, because the lead can pin down the leaflets and prevent the leaflets from moving. So these patients can develop tricuspid regurgitation. All right, so those are primary causes that condition affecting the valve leaflet themselves. Then secondary causes, if you have dilatation of the tricuspid annulus, the fibrous uh, ring that the tricuspid valve is inserted, if that's dilated, then you're going to prevent proper coaptation of the leaflets, and the patient will develop tricuspid regurgitation. Right ventricular enlargement, the same mechanism. So, and again, if the patient have LV dysfunction, whether it is systolic or diastolic, then you can build up the pressure all the way back to the pulmonary system. Patient develop pulmonary hypertension, and they put a strain on the RV and cause tricuspid valvular regurgitation. And so left heart disease is a very common cause of tricuspid regurgitation. So any cause of pulmonary hypertension for the same reason, will cause increase in the pressure in the RV and across the tricuspid valve, cause the tricuspid valve to leak. Okay, so things like COPD, pulmonary thromboembolism, left to right shunt, anything that causes pulmonary hypertension. And any cause of RV dysfunction as well can cause some degree of tricuspid regurgitation. So these are secondary causes. Primary causes, we talk about the valve itself, and then secondary causes are other things. So what are some of the signs and symptoms of tricuspid regurgitation? A lot of times these patients have absolutely no symptoms. They come to the echo lab and you pick it up. Again, upwards of 70% of normal patients, and it's more like 80, 90% of normal patients have some degree of tricuspid regurgitation. So usually asymptomatic. However, if they have significant tricuspid regurgitation, then they can have what we call decreased exercise tolerance once they start exercising because they cannot increase the cardiac output. Then they feel fatigued and tired. So fatigue again, ascites, because significant tricuspid regurgitation, you're going to get increased blood in the right atrium, increased blood in the inferior vena cava, and goes all the way back. So, and you're going to increase your venous pressure in the abdominal cavity, giving rise to ascites. Congestive hepatopathy, again, the same thing, increase volume in the right atrium, inferior vena cava. You're gonna the capsule of the liver is gonna get engorged, and the liver is gonna be enlarged and sometimes tender. Peripheral edema for the same mechanism, decreased appetite because of decreased cardiac output. Um, uh, if you have hepatomegaly, okay, engorgement of the liver, that can cause decrease in appetite as well. Abdominal fullness from the ascites and hepatomegaly. Hepatomegaly is enlarged liver. Neck pulsation, because increase volume in the right atrium, increase the jugular venous uh, pressure, and you get jugular venous distension. So neck pulsation. The classic murmur for tricuspid regurgitation is a systolic. That ola mean all throughout systole, systolic murmur, heard best at the left lower sternal border, and it increase with inspiration. Remember, almost all your right-sided murmurs increase with inspiration. It's an systolic murmur, heard best at the lower left sternal border, increase with inspiration. The difference between the tricuspid regurgitation murmur and the mitral regurgitation murmur is usually location and what happens with inspiration. With MR murmur, with inspiration, the MR murmur decrease, and the MR murmur is usually heard best at the apex. But remember, tricuspid regurgitation and mitral regurgitation, same type of leak. One is across the tricuspid valve, and the other is across the mitral valve. The location is going to be different, but it's the both usually systolic murmur. All right. So again, echo is crucial in evaluating tricuspid regurgitation. You can use your echo to determine the etiology, what caused the TR murmur. Again, if the patient have a pacemaker lead, which is impinging on the tricuspid leaflets and preventing proper coaptation, you can see that. Okay, and you not only you can see it, but you can determine the severity, how severe it is, by doing your Dopplers. So when we look at when we do the 2D, all right, let's see something. All right, so when we look at the tricuspid valve just with two-dimensional echo, you can see a number of things. You can see the leaflets And with the different views, you can see your posterior uh, tricuspid leaflet, you can see the septal leaflet, you can see the anterior leaflet, and you can determine which one of the leaflets is causing the problem. It may be all three. You can see things like thickness, how you know how significant is the thickness of the leaflet. You can see insertion. Remember we said Epstein anomaly is apical insertion of the septal leaflets. You can look and you can see that. You can see how well the leaflets are moving. If the leaflets are, separated, if they're stenotic, yes or no. But not only that, you can measure the size of the right atrium, the right ventricle, and the size of the inferior vena cava. So all of those things is important when you're assessing the tricuspid valve. So with your parasternal long axis view, um, well, this is your RV inflow view. So again, everybody know how to get your RV inflow view, and this is what the cartoon looks like. Okay, so this is the cartoon. The RV is on top, and the right atrium is down the bottom. Okay, of course, these are the papillary muscles are right here. The papillary muscles are right here, and this is the coordinate tendonae, okay, and it anchors the leaflet. So with your RV inflow view, this is the posterior leaflet, and this is your anterior leaflet. You have to know that because if you're doing the exam or you're studying a patient and you see something on this leaflet, you have to know it's a posterior leaflet. Okay. This is the eustachian valve right there. Coronary sinus is usually down here, and the inferior vena cava is usually right there. So this is the actual two-dimensional image. The RV is right there, RA is right there. This is your tricuspid valve, the posterior leaflet, anterior leaflet. Cords are usually they're attached to the papillary muscles. Okay, this is the eustachian valve. Coronary sinus is usually down here, inferior vena cava is right there. So you have to know your anatomy, okay? And when you're doing when you're scanning the patient, you have to know, what's happening. So if you're gonna tell me that there's something wrong with the tricuspid valve, you have to be able to say, well, the posterior leaflet or the anterior leaflet. You tell me that's the tricuspid valve, it's probably more confusing to me. I need to know which leaflet is has pathology. All right, so this is a modified view, really, looking at the RV outflow tract and the pulmonary valve. So you have to know how to get these modified views because sometimes it's necessary, especially if you want to look at uh, the distal right ventricular flow tract. You want to look at the pulmonary trunk and the bifurcations. Okay, you might want to. All right. Right, the size of the right atrium. Um, you have to know how to do that. Um, we measure the important thing about the right atrium though is the area. That is the important thing. You have to know the area for the right atrium. Uh, and 18 centimeter square is the number to remember. Anything greater than that suggests enlargement. All right. Uh, all right. Now, how do we determine the severity of tricuspid regurgitation? Now, you can look at your color flow, but there are other things that, very important. Just like we did piece of MR, AI, you can apply pizza to the tricuspid regurgitation, and it's probably one of the most accurate means of assessing tricuspid regurgitation. So when you look at your color flow Doppler, the characteristics of the jet um, is important. I mean, we talk about a Coanda effect. Once you see Coanda, that is, it loops around the wall, that suggests severity. Um, the size of the jet, anything greater than 40% of the area of the right atrium suggests severe. The vena contracta, the width of the vena contracta, remember? So that is one of the most accurate means of determining the severity of mitral and tricuspid regurgitation. And then the other features of the other pizza measurements. All right, so if you look at this, and you can see that this TR, so you have the tricuspid regurgitation down here, and then you have the flow convergence on top. And once you do your baseline shift and stuff, you can measure your vena contracta, you can measure the pizza radius, and you can just apply it and get some numbers. All right. So when your C continuous wave Doppler is also very important in tipping you off as to the severity. If you get a faint continuous wave Doppler like this, then you know it's not severe. So a faint TR signal, it's not severe. And if the contour is rounded, you know, then it's you probably not severe. All right. If the contour is triangular, and if it's deeply, if it's triangular, and if the density is very dense, then that suggests severity. So something like this, it's faint and it's rounded, more than likely it's not severe. All right. Again, so just like your mitral regurgitation, when we talk about severe TR, what you're saying is a lot of blood is going from the RV across the tricuspid valve into the right atrium. So therefore, when the tricuspid valve opens in diastole, a lot of blood is supposed to come back. So you need to get a very large E velocity. If it's a significant TR, large E velocity. But even more important, your hepatic vein flow. Don't tell me that the patient has severe TR without assessing the hepatic vein flow. With severe TR, you're supposed to get systolic flow reversal. Just like in the mitral case, you get in the pulmonary vein flow, you get systolic flow reversal. So you have to make the statement convincing, because remember, this is not just an exercise in futility. It's the assessment is going to impact how you treat the patient. So get all the information to make a correct assessment. So again, when you do your tricuspid inflow, you're gonna get big E velocity, just like your MR. Okay, and then with your hepatic vein flow. So these are two scenarios: one with mild TR and the other one with severe TR. So with your mild TR, of course, you can see a little bit of color, less than 20% of the right atrium. The C doubler is faint, the contour is rounded. The hepatic vein flow, your systolic component, your diastolic component and your atrial flow reversal, they're both below the baseline. But with severe TR, you can get a lot of color. You see the color more than 40% of the right atrium. The CW is very dense, triangular contour. And then when you look at your hepatic vein flow, you get systolic flow reversal. Systolic component is above, the diastolic component is still below, and your atrial, you get atrial flow reversal. Your ECG is on top. So severe TR, mild TR. All right. So you need to know what are the features of severe um, uh, TR. Okay. Um, so we're gonna stop here, and then when we come, our next session, we will go into the pulmonic valve.